Should we start?
Yeah.
Thank you, Dr. Vipul. A very good morning to all of you, for all those who have joined on behalf of Delhi chapter of Indian Academy of Pediatrics, Indian Association of Pediatrics, and also on behalf of Society for Promotion of Education in Endocrinology and Diabetes, which is SPEED. So this is our sixth session on the Type 1 Diabetes Education Program. And we have the pleasure of introducing Dr. Lakshmi Nagendra. She is a consultant associate professor at JSS Medical College, Mysore. So she is one of the most dynamic and promising endocrinologists in India. Multiple publications already, a master in doing meta-analysis, and also has a deep and keen interest in osteoporosis and bone mineral research. So today we will be talking about the glucose monitoring technology. So I think it's one of the very crucial part of type 1 diabetes management. So we need to get the information on the basis of which we take our decisions and formulate our strategy for management. And I won't take much more time. I will hand it over to Dr. Lakshmi for carrying forward the session on glucose monitoring devices in type 1 diabetes management.
Thank you, sir. And thanks to SPEED and IEP for this wonderful opportunity to talk to you all today. I'm just going to share my screen. My slides visible?
Perfect.
Yeah, it's visible.
Okay. So good morning, everyone. Today we'll be talking about glucose monitoring, meters, and CGMS. So the first part of this talk, I'll cover glucometers. Starting off with a case. So we have a 15-year-old child. I'm sure all of you must have come across this clinical scenario very often in your clinic. So a 15-year-old child with a 5-year history of type 1 diabetes presents with complaints of abdominal pain and 2 episodes of vomiting. She uses 30 units of insulin daily in 4 divided doses with pre-meal short-acting insulin and also basal insulin at bedtime. She records that her blood glucose, which she checked at home, was around 280 milligram per deciliter. And she's examined and a glucose sample using a glucometer. The result is again 220 milligrams per deciliter. So the care provider chooses to verify this glucose result and actually sends it to the lab. And the laboratory glucose value shows as 512 milligram per deciliter with moderate serum ketones. So it's now clear that the patient actually has higher blood glucose than that was reflected in the glucometer and has all the signs of diabetic ketoacidosis. So she was treated as per the DKA protocol with intravenous insulin, fluids, and electrolyte repletion. Now, I started off with this case because it's important to remember that, the glucometer values that we are checking may not be accurate at all times. Now, especially in a case like diabetic ketoacidosis, it's very important to know what the actual level of glucose is. So why does this happen? Why do the changes, why do the glucometers sometimes show inaccurate values? Are they reliable? So we'll talk more about this. So before we go into the types of glucometer and what they do, let's look at the basic, the basic working of a glucometer, what actually is happening. So once you start with a drop of blood, the glucose reacts with the enzyme in the glucometer. Now, the enzyme can be glucose dehydrogenase or glucose oxidase. So these are the two most commonly used enzymes in glucometers in use today. So we have to remember that it could be the glucose dehydrogenase or glucose oxidase, coming to more on that later. So once glucose reacts with this enzyme, then it reacts with an intermediate. It forms an intermediate for which signal is generated after this. Now, the signal generated can be either photometric or amperometric. And if it is a photometric, it could be a reflectance photometry or a transmittance photometry. And after the signal is generated, that the reading is displayed. Then there could be a memory function or not based on the type of glucometer. Then, of course, we have the operability characteristics. So the operability characteristics include whether the data could be transferable to a computer or if the pretest calibration is needed or not. So this is how any glucometer works. This is what happens once the drop of blood is given to a glucometer. So going back in history, dextrosticks was the first blood glucose strip. This was issued way back in 1971, and we have come a long way till then. So I was talking about the technology for the signals generated in the glucometer. So we have two technologies, the optical technology and the amperometric, which is the electrochemical technology. So when we talk about optical technology, it could be a photometry or a calorimetry. Again, in photometry is the most commonly used today, and we have transmittance photometry or a reflectance photometry. And in amperometric glucometers, we have biosensors, which actually use electrochemical technology. So how does a reflectance photometry work? So we know that a white surface will reflect 100% of the light directed towards it. So you have a light source here, and this is reflected to a white surface, and this reflects 100% of the signals that is reflected to it. But in the white surface, if we have a colored surface, so the presence of glucose will make the white surface a colored surface. So a colored surface absorbs part of the direct light, and you can see that not all of the reflected light is directed. So we know based on the color or based on how much glucose is present, which will lead to the color of the surface, the light is absorbed, and henceforth signals generated will be equal to the glucose present. So this is how reflectance photometry works. So when we speak about it in simple terms, if we have more glucose in a sample, more colored product is formed, less reflected light, and there is a higher glucose result. If there is less glucose in a sample, less colored product is formed and more reflected light, and there will be lower glucose result. Now, moving on to transmittance photometry, what actually happens? So you have a light source. This is directed towards a clear solution, and all of the directed light is transmitted to the signal detector. So a clear solution will transmit 100% of the light directed towards it. But if you fill it with a solution, the glucose solution will be a colored solution. The signal, all of the signal that is directed is not transmitted, and hence the glucose can be quantified in this colored solution. So moving on to electrochemistry, what is actually a biosensor technology? So a biosensor is an electronic device that quantifies the number of electrons generated by the oxidation of glucose. So glucose is oxidized, and then electrons are generated, and this biosensor will actually quantify the number of electrons. So there are three main parts of a biosensor. There is a biological recognition element that differentiates the target molecules in the presence of various chemicals. Then there is a transducer that converts this biorecognition event into a measurable signal, a signal that you can actually measure. And then there's a signal processing system that converts the signal into a more readable form. So molecule recognition elements could be receptors, enzymes, antibodies, nucleic acids, and so on. So there are five principal transducer classes. They could be electrochemical, optical, thermometric, and so on. So majority of the current glucose biosensors are of the electrochemical type because of their better sensitivity and also reproducibility of the results. And they're also easy maintenance, and they also cost relatively less. So majority of the glucose biosensors that we have now are the electrochemical type. So what actually is the principle? So when we measure glucose, they are based on interactions with one of the enzymes. Like I showed in the first slide, glucose is actually interacting with one of the enzymes to give us a signal. So this could be hexokinase, or glucose oxidase, or glucose 1 dehydrogenase. So hexokinase is what we use for measuring venous plasma glucose. So when you send your glucose sample to a lab, the enzyme that is used is actually hexokinase, and the blood compartment used is venous plasma glucose. And when we use the glucometers, it could be either glucose oxidase or a glucose dehydrogenase. And hexokinase is the reference method for measuring glucose using spectrophotometry in many clinical laboratories and not in glucometers. So as we said, the biosensors for SMBG or the glucometers that we use are based on two enzyme families, the glucose oxidase and glucose dehydrogenase. Now, this is very important to remember because there are certain pros and cons of each of these type of enzymes that we have to remember and also know while we are interpreting the glucose values. So suppose you're using a glucometer when a child is undergoing dialysis and you have a reading which is which is unexpectedly high, then you should see the type of glucometer that you're using, and if it's a glucose dehydrogenase glucometer, then probably it could be a false result. I'll come more to it, but when we buy a glucometer, when we suggest a glucometer to our patients, it's very important to see what kind of glucometer the glucometer enzyme is using. So it could be a glucose oxidase or a glucose dehydrogenase. So glucose oxidase is the standard enzyme for a few biosensors. It has a relatively higher selectivity for glucose, and glucose oxidase is easy to obtain and can withstand greater extremes of pH and temperature. So when we talk about accuracy of glucometers, how do we say that a glucometer is accurate? So we have something known as a reference value. And we talk about accuracy, precision, and being both accurate and precise. So here you can see the left panel here. So this is a set of measured glucose values, which you can see in the yellow circles. And this is the line of identity shown. So the set of values of half of the values are high by 100 and half of the values are low by 100, but none of these values represents actually the reference value. So you can see that these are all above or below the reference line. So they are accurate, but they are not precise because they are not equal to the reference range. Now here you can see that these are precise. So all these values are high by 100. So they are very precise. So you're doing the same thing again. So you're getting 100, 100, 100, 100. They are precise, but they're again not the same as the reference line. Now here you can see that they are same as the reference line and they're also similar to each other. So they are accurate and precise, and this is what we want a glucometer to do. So we also have criteria, certain set criteria for glucose meter performance. So we have the ISO standards and also the FDA standards. So for home use, according to the ISO standards, the 95% of your measured blood glucose value should be within 15% for a blood glucose value of more than 100. So if you are doing 100, 100 values, 95% of them should be within 15% of the standard for glucose values more than 100, and 95% again should be within 15 milligram per deciliter for blood glucose less than 100. Then only you can say that your glucometer performance is good. And for hospital use, we have something known as a consensus error grid, and 99% of your measured glucose value should be in this A or B region of the consensus grid. So this is the consensus grid, and 99% of the glucose values that you're measuring should be in these between A and B to be called a good performance by a glucometer. So what is technical accuracy? So we spoke about the measurement. There should be a closeness of agreement between a measured quantity value and a true quantity of glucose. And for an accuracy determination, glucose values from the same specimen should be compared by analysis on the glucometer and by a reference or a comparative method, ideally from the lab. So the inaccuracy of glucose monitoring systems comes from various sources. So it could be because of the strict factors, it could be because of the physical factors, it could be because of the patient factors, and it also could be because of the pharmacological factors. So we have to keep all of this in mind when we are interpreting a glucose value. So what are the strict factors that you should know of when you're measuring a glucose value by a glucometer? So there is something known as the reaction wells in a glucometer, which are the sample chambers. So in some types of glucose strips, the individual reaction wells, these wells in the strips are small, and a well size variation of even 50 micrometer will lead to a 3% error. So there could be changes in the reaction wells, which could lead to wrong value. There could be changes in the enzyme coverage also. So the enzyme coverage by the glucometer can also lead to different values in the glucometer. So when we talk about other strict factors, so reduction of the mediator in the glucometer can cause problems with accuracy. When they are exposed to very high temperatures above 40 degrees Celsius for a long period of time, they can be inaccurate. So we have to remember that strips also have a finite lifespan, and they should be usually used under 2 years under ideal circumstances and ideal storage circumstances, which is usually less than 40 degrees. So storing strips at high temperature with high humidity will actually cause wrong values from these glucometers. So you can see here at 40 degrees and the time in months, as the time in month increases, the glucose value, the measured glucose value is also increasing, and therefore it's not accurate. So what are the physical factors that can also influence the reading of these glucometers? So altitude is one. So when we talk of altitude, the glucose oxidase biosensor. So we spoke about two types of glucometers, the glucose oxidase and the glucose dehydrogenase. So the glucose oxidase biosensor strips are often sensitive to oxygen concentration. And both the mediator and oxygen can compete with each other to take electrons. And that is why we get false readings. So if the oxygen is low and you're using a glucose oxidase meter, the glucose oxidase meter may actually report a value higher than the truer value. So if you're at a high altitude and the oxygen saturation is low and you're using a glucose oxidase glucometer, you should actually check it with the lab to see if the meter reporting is actually true. Or you could also switch to a glucose dehydrogenase glucometer in such circumstances. What about temperature? The temperature is less predictable. It can either cause higher values or lower values. And most meters actually have a temperature sensor and will report errors at very high extremes of temperature. So coming to patient factors, now this is very, very important because we have to be educating our patients on actually what factors from them can cause wrong reading in a glucometer. And this has a great influence on the accuracy of a blood glucose meter. So patient technique is very important. For example, there was a study done to see how many patients are actually washing their hands before using a glucometer. So washing hands is very, very important because you can have food particles on your hands before checking the glucometer, and that can lead to a falsely high value. And again, after washing your hands, if you've not dried your hands properly, it can lead to dilution and again give a falsely low. So only 9 to 20% of patients were actually using the correct technique of using a glucometer in various surveys. So that's a very, very dismal number, and most of our patients don't actually know what is the correct way to use a glucometer, and this can lead to fallacies in the glucometer as well. Again, patient factors, hematocrit is very important. Variation in hematocrit can cause serious errors in blood glucose. So we should always be interpreting like how we interpret venous plasma glucose or a HbA1c, in the context of a hematocrit. This should also be interpreted based on how the hematocrit is in our patient. So again, we have to remember that in the fasting state, arterial glucose levels are about 5 milligrams per deciliter higher than capillary and 10 milligram per deciliter greater than venous concentrations. So I always get these questions that patients are saying that glucometers, when they do sample in a glucometer and they give the same sample to a lab, it's not the same. So the glucometer is showing a higher reading. Why does this happen? Is the glucometer wrong? Is the lab wrong? What actually is happening? So we should actually be educating our patients that the glucometer and the lab samples, we are measuring glucose from different compartments. So in the glucometer, we are usually measuring the capillary blood glucose. In the lab, we are measuring the venous plasma glucose. So these are actually different compartments, and both of them are measuring blood glucose levels in different compartments. So both of them are right in their own ways because they are not measuring the same blood glucose. And again, there can be differences between arterial and venous blood samples because of decreased perfusion, and they can also be decreased oxygenation. So this is very important to tell the patient that, in the fasting state, if the patients are measuring in the fasting state, capillary glucose is 2 to 5 milligrams deciliter higher than the venous glucose. So suppose a patient is fasting and takes a glucometer to the lab, gives a venous plasma glucose. So venous plasma glucose can be around 100. And if the patient does in the capillary blood glucose, it could be 105. Now, is this correct or wrong? This is actually correct because the patient has measured a capillary glucose, which is 5 milligram deciliter higher than the venous glucose measured by the lab. So in the postprandial state, this becomes even more important because capillary blood may be 20 to 25% or greater than venous level. So you give a postprandial sample, patient goes to the lab and gives a postprandial sample. So in the lab, it could be around 200. Now, 20% of 200 is 40. So if you do the capillary blood glucose in the glucometer, it can be 240 in the glucometer. Now, this is very important for the patient to know that the glucometer is actually measuring a different compartment, right? So, and in poor perfusion, like in states such as shock, can lead to capillary and venous difference in glucose as well. So, summarizing this, effects of various physical conditions on glucose measurement. When you talk about anemia, which is very, very common in our patients, if you use a glucose oxidase glucometer or a glucose dehydrogenase glucometer, the values can be increased. And in reverse, polycythemia can actually decrease the glucose values in both glucose oxidase and glucose dehydrogenase. Now, there are various other factors that we spoke about. And we also should remember, like we saw in our first patient, that diabetic ketoacidosis, where the pH is decreased, can actually cause a low blood glucose reading in the glucometer. So it's a standard practice that, whenever a patient presents with diabetic ketoacidosis, a lab sample should also be sent in addition to measuring the glucose with the glucometer. So we have the correct value, because pH, a low pH like we see in diabetic ketoacidosis, can actually decrease the glucometer values and lead to falsely low values. So two types of main glucometers would be glucose oxidase and glucose dehydrogenase. Two simple things to remember is glucose oxidase glucometers are less affected by oxygen concentrations, and they have less chemical interference. Glucose oxidase is affected by oxygen concentrations, and they have less chemical interferences. So if you're using, a patient is at high altitude, you should be actually telling the patient to be using a glucose oxidase, because you should not be telling the patient to use a glucose oxidase, because this is affected by oxygen concentration. So high altitude, use a glucose dehydrogenase glucometer. Most of our glucometers are actually glucose dehydrogenase glucometers today, but glucose dehydrogenase glucometers are also have interfering, they have interferences with other sugars. So coming to another example, case 2. So this is a 15-year-old child with history of diabetes and acute kidney injury. This patient is receiving peritoneal dialysis. So during the dialysis, a glucometer reading is 256 milligram per deciliter, and supplemental insulin is given to the patient. 3 hours later, glucose is checked again with the glucometer, and this shows as 284 milligrams per deciliter, and supplemental insulin is double. So 1 hour later, the patient becomes comatose, and patient begins having uncontrolled seizures. So this actually led to hypoglycemia. But what's the problem here? So we did the glucometer reading twice, it's showing high, and then we gave insulin, but the patient actually went into hypoglycemia. So here the patient may be using a glucose dehydrogenase glucometer, and glucose dehydrogenase glucometer is subject to interference by a number of things like maltose. So if you use icodextrin in peritoneal dialysis in patients, this can get converted to maltose and actually interfere with the measurement. So if you're using a glucose dehydrogenase glucometer like in our patient 2, this can lead to a falsely increased reading of the glucometer. So the values that we saw of 250 and 280 are actually falsely high because of the maltose interfering with the peritoneal dialysis solution. So again, looking at the summary of pre-analytical errors on glucose measurement that can affect the glucometer reading. So we spoke about exposure of strips to elevated temperatures that can cause a low reading, and exposure of strips to decreased temperature can actually cause a high reading. Exposure to humidity, vibration, or dirt can increase the values either ways, up or down. Out of date strips are not accurate. Failure to calibrate strips will lead to low values. Failure to wash hands and even dry hands will lead to low values. And also inadequate drop size can also affect your glucose readings in the glucometer. So that's all about glucometers. And should we take questions at the end of it, or at the end of CGM as well?
End of it. End of all.
End of it. Okay. So I'm actually going to stop sharing now and share another PowerPoint slide. Just give me a minute. Is this visible?
Yes, ma'am. Yes.
So after glucometers, we are going to talk about continuous glucose monitoring. A brief overview of what continuous glucose monitoring is, what you can do with continuous glucose monitoring, what are the devices available in India, and what are the pros and cons of continuous glucose monitoring when you compare it with SMBG from glucometers. So we know that HbA1c is the gold standard indicator of glycemia and correlates with the complication risk. We've been using SMBG for decades now, and it has been shown in various trials to correlate with the complications of diabetes, correlate with the prognosis and various other factors in diabetes. So then why do we need something else? Why do we need to go a step ahead of HbA1c? So does HbA1c tell us everything? For example, take these patients. So you have example 1, example 2, and example 3. All of them have a HbA1c of 7%. So here you can see that all of them have a similar HbA1c. So they come to the clinic, you measure the HbA1c, they have 7%, all three of them have 7%. So does this mean that they have uniform glucose readings throughout the day? If you look at these graphs, they actually have a high difference in their glucose values, and HbA1c is not actually giving us the full picture of what is happening. So here you can see that 100% of these glucose values can be in range, 63% of glucose values can be in range, and even as low as 18% of the glucose values can be in range and still give you a HbA1c of 7%. So they are different, and HbA1c is not giving us the full picture of what's happening in our patient. So SMBG with a glucometer gives us snapshots. So you know what's happening when the patient wakes up, or when the patient checks before lunch or after lunch, before dinner or after dinner, bedtime. So this is actually a snapshot of what is happening at various intervals and does not give you a good picture. So when you do a CGM, continuous glucose monitoring, it shows the whole movie of what's happening in a patient's life. So from breakfast to till the patient goes to sleep and again wakes up again, you know what's happening. The highs here, there's a low here, there's high here, there's low here. And if you were doing only SMBG, so you would have done 140 here and you would have done 100 here, but you have not captured the hypo here. So it gives us the full movie and it gives us a full picture of what is happening, because it's not only important to treat the hyperglycemia, but we should also be treating the hypoglycemias and taking care that the patient doesn't go into hypoglycemia while maintaining good glucose values. So what is continuous glucose monitoring, or CGM? So before we go into this, I just came across this very interesting fact, and I also learned about it very recently myself, that CGM and CGMS is not the same. So we actually use one instead of other, CGM, CGMS, but what actually is it? So CGM is this, what we're talking about today, continuous glucose monitoring. But a CGMS is actually a trademark of a company. So if if you want to mention CGM, you should be mentioning only CGM and not CGMS. And it's not the same as CGM because it's actually a trademark used by a company to denote CGM. So when we talk about continuous glucose monitoring, we have three components. We have the sensor, transmitter, and the receiver. So this is actually measuring the interstitial fluid in the glucose. We spoke about various compartments, venous compartment and the capillary compartment. Now this is actually not measuring glucose in the blood, but it's measuring glucose in the interstitial fluid. And you can have every 5 minutes reading up to 288 readings per day. So you have a glucose sensor in the interstitial space, which is measuring the interstitial fluid glucose. There is a wireless transmitter and there is a receiver to receive these signals. Now, it's very important to know that when we are sending a glucose value to a lab, this is measuring a venous blood glucose. And when we are when we are doing a glucometer value, it is measuring capillary blood glucose most often. And when we are doing a CGM, it is measuring the interstitial blood glucose. And these values are not the same all the time. A venous blood glucose value can be lower than a capillary blood glucose, like how we spoke about. So there is a sensor here, and a sensor has glucose oxidase enzyme matrix and an amperometric electrode. And a production of these electrons upon oxidation of glucose generates this electric current, which will give us the signals and this is transformed into glucose readings that we can Just see. So what actually is displayed when you put a patient on CGM, what actually is displayed? So you have a current glucose reading, you have a trend graph which shows whether it's going high or the trend is towards lows. You have the trend arrows, and also you have alarms for high and lows in certain CGM. So there can be alarms in continuous glucose monitoring systems that can warn patients of current or high projected high and low blood sugar, even actually before going into hypo. So you can set up a threshold alarm. That's a warning which tells the patient that the trend is towards low, and if the patient does not take any action, he can actually be going into a hypoglycemia, so that the patient can take a corrective action before he actually goes into a hypoglycemia. So what are the types of CGM that is available today? So we have a blinded CGM, a real-time CGM, and an intermittently scanned CGM. So a blinded CGM is when a patient has no access to readings. Data can be downloaded in the clinic and interpreted. So both the patient and the doctor is blinded to what is actually happening in the CGM. A real-time CGM displays the glucose readings and graphs in real time. So it can also provide alarms and alerts to the patient. In real time, it's telling you what actually is the blood glucose now. So the patient is not blinded, and anybody can see these values. You also have another sort of CGM, which is known as the intermittently scanned CGM. So this has a provision to display the glucose readings and graphs when the sensor is scanned with the reader. So there's a reader and there's a sensor, and whenever the patient scans the sensor with the reader, it will show you the glucose value. So three types: blinded, where both the patient and the care provider is blinded to the type of CGM. Real-time CGM will show you the values in real time, and intermittently scanned CGM, you can scan it intermittently to know the glucose values when you would wish to. So what is the difference between a real-time versus an intermittently scanned CGM? So a real-time CGM provides current values, trends, alarms, but there's need for calibration, and the sensor can work for about 3 to 5 days with a good accuracy. And for an intermittently scanned CGM, the biggest pro for an intermittently scanned CGM is there is no calibration, and you can use it up to 14 days. You can actually see the current value, and you can also see the graph of the last 8 hours. So talking about the types of CGM devices which are currently available in India. So we have the professional CGM, also the blinded CGM, which is the Medtronic iPro 2 and Abbott Freestyle Libre Pro. So this is a professional CGM which is blinded, and the flash CGM, sorry, there's a mistake on this. The flash CGM is actually the Abbott Freestyle Libre. Flash, this will tell you the glucose values when you flash it, and you have the real-time CGM, which gives you the real-time glucose values, which is the Medtronic Guardian Connect and also the Dexcom. So how does a real-time CGM impact diabetes care? So does it assist the patient and clinician? It, of course, is a very, very big boon for both the patient and the clinician, because early detection and even prediction of hypos, also nocturnal and asymptomatic hypos, can be done with the CGM. Early detection of glycemic excursions can be done. The highs and lows can be detected and even predicted. Fine-tuning the insulin dose based on these can be done, and behavior modification of the patient can be done based on the glucose excursions. And for the clinician as well, it is a big advantage to evaluate and quantify the glycemic variability. Now we speak about glycemic variability, which is another metric in glucose management in diabetes. It's a tool for patient education. So you can tell the patient that what is the impact of any type of diet. So the patient, it's different for all patients. One patient eating chapati, it may not be good for this patient. It can actually increase the glucose values. You can also talk about carbohydrates that the patient is consuming, what impact it is having on the glucose values. You can speak about exercises and the impact, and medications in glucose. So when the patient actually sees what exactly is happening with a certain sort of diet or a certain sort of exercise or certain sort of medications, patient learns. So there is self-learning to the patient, which happens, and this is a tool for patient education. So once a patient has a sweet and see that the glucose values is going up to 300, it's unlikely that the patient is going to do such a thing again, do it repeatedly again. So this again automatically leads to a better control. And you can also use this for titration of therapies, especially insulin, to improve glucose control, especially in type 1 diabetes. And in clinical studies, you can use it to understand the impact of various treatments. So there are various evidence and benefits in type 1 diabetes. So when used, it causes significant reductions in HbA1c, less time is spent in hypoglycemia, reduced risk of nocturnal and even daytime hypoglycemia, reduction in severe hypoglycemia, reduction in glycemic variability. But most important is improvement in the quality of life. So a patient using any patient that you put on CGM will report an improved quality of life at the end of even 5 days. I have patients coming back and telling me that, I never knew that my life could be so easy. Somebody is actually watching out for me. Somebody is giving me alarms that there could be highs, there could be lows. So this is actually very beneficial in glycemic control and also in improving the quality of life in patients, especially with type 1 diabetes. And the benefit of CGM use directly correlates with frequency of use. So it actually benefits in patients who use CGM or are likely to use CGM for at least 70% of the time. So, and how do you interpret a CGM report? So going into the basics, a very few basics of how you interpret this report. So we have various metrics in interpreting a CGM report. The most commonly used ones are the time below range, time in range, and time above range. So when we speak about this basics, so this is when you put a patient on a CGM, you get a report like this. So here you can see that you have set a target in range. So you have set a low target of 70 and a high target of 120, 180, and any glucose values in between this, you call that it is in range. So anything above 180 will be recorded as time above range, and anything less than 70 will be recorded as time below range. So we spoke about the target range. So you have actually set it to 70 to 180. This can also be changed, but mostly set at 70 to 180. So what exactly is time in range? So you have time in range here, which is denoted by this graph here in gray. So you have in this patient, for example, 92% of the time that the patient is wearing the glucometer, wearing the CGM, sorry, the time is in range. In our case, what we spoke about, it is between 70 to 180. And in 1% of the time only, the time is below range. And what about time above range? 7% of the time that the patient is wearing the CGM, it is above the range. So 92% time in range. So this is actually good for this patient. And this is also correlating with the mean glucose value of 125. So time in range is actually the percentage of time that you spend between glucose values of 70 to 180, to put in simple words. So here you have a graph. Here you have 70 and here you have 180. In this yellow graph here, you have 180, 1 to 250, and this orange part of this graph, you have more than 250. And here you have values up to 54 here, and this is time below range, below the green. So anything in green would be time in range, time above range, and here would be time below range. So in simple words, what we spoke about, time in range is glucose between 70 to 180. And what actually is the target? When you speak about time in range, time above range, and time below range, what actually should you be telling your patients about how they should be maintaining this time in different parts of this graph? So we aim for a time in range above 70% in our patients. So time in range should be above 70% for you to, tell that this patient has achieved a good glycemic control. And time below range in level 1 should be less than 4%, and time below range in level 2 should be actually less than 1% to achieve a good target. So is there a correlation between the target time in range and a HbA1c? Can you actually correlate with the HbA1c? Can you tell that, looking at the time in range, this could be a HbA1c of approximate this much? Definitely there is a correlation, but we have to remember that it is a negative correlation. So higher time in range leads to a lower HbA1c. So a time in range of about 70% correlates with the HbA1c of 7%. So most of our patients may be used to, interpreting their glucose metrics in terms of HbA1c, and you put on CGM and then tell the patient that you are actually having an approximate time in range of 70%. So this could correlate with the HbA1c of 7%. So this is a table which will tell us approximately how much it is. So about 70% will be around 6.9 to 7%. 80% will be about 6.5%. And if you go, it's a negative correlation. A time in range about 40% will lead to a HbA1c of about 8.1%. So it is negative. So absolute change in time in range again of about 10% was associated with a change in HbA1c of 8%. So you tell the patient that if your time in range goes by 10%, it is equal to the HbA1c going up by about 0.8%. So time in range more than 70% is the target, is the ideal target in both type 1 and type 2 diabetes. And when we look at time in range and the risk of diabetes related complications, again, it correlates well with the diabetes complication, and a lower time in range assessed by the CGM is associated with an increased risk of diabetic retinopathy in all patients with type 2 diabetes. So there have been various studies on this, and for every 10% decrease in time in range, there is an increase in risk of microalbuminuria, almost a 40% increase in microalbuminuria, about a 60% increase in risk of retinopathy, and almost a 25% increase in diabetic neuropathy. So there, every time there is a 10% decrease in TIR, your risk of diabetes complications goes up by, as close to 60%. So that is important. You tell the patient that, if you're spending 60% of your time in range instead of 70%, your risk of retinopathy is actually higher by 60%. So that is quite significant. And this is the most often question that I get: will CGM replace HbA1c? Will a time and range metric replace HbA1c? Definitely not. It may not replace HbA1c, especially in India, because we don't have the access. As of now, majority of our population do not have access to CGM, and we are struggling to do a HbA1c in so many of our patients who cannot afford to do HbA1c even. But many studies have shown that time in range is an important mental and emotional consideration for people with diabetes, particularly for those taking insulin. So they have, from the patient perspective, it is a better metric as well. So they know they're actually spending this much time in range, above range and below range, and it actually leads to better patient quality of life. And from a patient perspective of view as well, this is a better metric. And other advantages of time in range over HbA1c, you see that time in range is very useful in conditions in which HbA1c is unreliable, like you have CKD, hemoglobinopathies, where HbA1c is very unreliable and you want to know what exactly the glucose control is. You can use time in range. And it also reflects hypoglycemia better than HbA1c. And when we speak about glycemic targets today, it's very personalized, and it's not one glycemic target fits all. So for example, for all patients with type 2 diabetes or for all patients with type 1 diabetes, you cannot say that, they should achieve a HbA1c of 6.5%. So it's not a one size fits all approach that we use. It is based on disease duration, life expectancy, comorbidities, vascular complications, that we actually personalize how much the glycemic target should be in each of these patients. Generally, in patients with type 1 and type 2 diabetes, we aim for a target range of more than 70%. So we want a target range of 70 to 180. We want the patient to spend about 70% of their time in 70 to 180 range. We want them to spend less than 4% of their time below 70, and we want them to spend less than 1% of their time less than 54. And when we speak about time above range, we want them to spend less than 25% of their time above 180 and less than 5% of their time about 250. So these are the important numbers to remember. 70% for most type 1 and type 2 diabetes patients. Again, it's not written in stone. It's not applicable. We should actually be looking at patient comorbidities, their support, what kind of support they have, what kind of medicine access they have, what are the complications they have, and personalize this. But as a rule of thumb, more than 70% is a good glycemic target to achieve in both patients with type 1 and type 2 diabetes. There are again limitations of CGM. So there are actually accuracy issues with CGM as well. The time lag is about 5 to 15 minutes. You actually have a lag of 15 minutes for the glucose values that the reflecting glucose values, there is a lag. And there are issues with precision. There is need for calibration. There could be substance interference, like how we see in glucometer, and they're also unreliable during hypoxia, hypotension, and hypothermia. So user challenges, again, cost is a major factor. Most of our patients are not able to afford it, and they still have to do finger prick for calibration even while using a CGM. And some patients report discomfort while using a device continuously. So it also requires technical skill and education for the patient, and there is patient uncertainty as well, as to how best to use CGM and interpret the reports. So report interpretation again is a big challenge for the patient, and there could be alarm fatigue as well in some patients. Some patients just tell, this alarm keeps ringing all the time, and it's not letting me do anything. I'm just so tired of it. So there is this kind of concern as well, and of course there are insertion site issues, rashes, infections again that can be associated with it. So when we look at the international consensus on the use of CGM, this should be considered in conjunction with HbA1c for glycemic status assessment and therapy adjustment in all patients with type 1 diabetes, and in patients with type 2 diabetes on intensive insulin therapy who are not achieving their glucose targets, especially if there is problematic hypoglycemia. So the bottom line here is they should be considered for all patients with type 1 diabetes in our setting. If you look at the ISPAT clinical guidelines, again, for children, adolescents, and young adults with diabetes, use of CGM is strongly recommended in all children, adolescents, and young adults with type 1 diabetes. So in all of these patients, it is recommended, and where available, it should be initiated in all children, adolescents, and young adults as soon as possible after diagnosis to improve glycemic outcomes. And the intermittently scanned CGM, also known as the flash glucose monitoring, in the pediatric population is safe, and it may improve time in range and HbA1c levels and decreases time in hypoglycemia and lowers glycemic variability, like how we spoke about. And when we speak about scanning frequency, what actually should we tell the patient? How many times should they be scanning? So about 11 to 13 scans per day is considered favorable, to have a good glycemic outcome as measured by HbA1c or time in range. Again, A1C, we said, that has several limitations as a glycemic marker in CKD, and CGM could be actually very good for use in patients with CKD, and they are approved for use in CKD and dialysis patients as well. And studies have suggested that CGM could improve glycemic control in dialysis patients. So, but we have to remember that CGM, whatever we spoke about, CGM is primarily a diagnostic technique. It's actually diagnosing the blood glucose values. It's not giving any therapeutic intervention, and it cannot be expected automatically to improve glucose control per se. So you tell the patients are actually thinking that you put the patient on CGM, and the glucose values get better by its own. So it's not actually that. We have to be educating our patients that they should learn to use a CGM. They should learn to interpret the reports, and learn from the reports what actually is happening with food, with exercise, what is happening at different times of the day, which can actually translate to a better glycemic outcome. But it requires a lot of effort from the patient and from the caregiver as well. So it is just like a weighing scale, and weighing scale just shows you the weight and cannot be expected to reduce weight per se. So this is just like that, a diagnostic technique. So now we are moving from glucose monitoring, keeping your sugar levels in check one prick at a time, to glucose monitoring, keeping your sugar levels in check without the prickly interventions with the CGM. So we are, a lot of our patients are able to afford CGM, but I would say the majority of our patients still have, still do their glucose monitoring by glucometers and SMBG, and it's important for us to know the various fallacies of glucometer as well, like we spoke about. So these are my acknowledgements to my dear seniors for helping me with this presentation, and thank you one and all for your patient listen.
Thank you,
Thank you, Dr.
Okay.
Lakshmi. Dr. Adarsh has joined as the chairperson. Would like to take his comments first. I think that was a wonderful, very practical, and a very exhaustive session. So you covered almost all the practical nitty-gritties related to glucose monitoring, both related to glucometers as well as CGMS. Dr. Adarsh, your comments, please. Yeah.
Very good morning to all, especially my Delhi IAPNs. And first of all, I thank Delhi IAP for inviting me as a chairperson to this. I've gone through the detail about completely regarding what Dr. Lakshmi Nagendra she spoke. It's a really excellent one, and especially the continuous glucose monitoring what she was highlighting. But I'm worried actually there are a lot of limitations, Madam said. Madam, just I wanted to clarify because I run a CDC center where where I'm going to distribute free of cost insulin to all my children of juvenile diabetes. So such cases, see the role of CGMC, the continuous glucose monitoring system, whether especially the affordability, because all children those are coming to my clinics are really socioeconomically they are deprived. So I mean, whichever the GCMC monitoring, which can be helped to them, and especially you already told that adolescent as well as even nowadays we are getting a lot of every weekly one case of diabetes mellitus juvenile. So how to go ahead with this such young children? What's your experience regarding this, madam?
So nowadays, practically speaking, we have the Abbott Freestyle Libre Pro, which is a blinded CGM. Many of us are getting samples for patients, like how we give insulin free. Many of the companies are actually, giving this as goodwill. I'm able to do this in many of my type 1 patients without much cost to the patient. And even if you are charging the patient, because it's a blinded CGM and you have the reader with you, right? So the reader is with you, the patient puts the sensor, goes back for 7 days, and then what I do is I put the sensor, the reader is with me. The most common CGM that I use is a blinded CGM, the Abbott Freestyle Libre Pro. So I put the sensor, the patient goes back home for 7 days, comes back, we download the report, look at what's happening, and try to intervene after 7 days, and again see after 7 days if these interventions have caused any improvement in what we saw in the last 7 days. So you can actually use these 14 days period even in a blinded CGM to bring about meaningful interventions. And even if the cost, the patient is paying for the cost, it is about 1,500. So this is very inexpensive, comparatively inexpensive. And if you do it once in 6 months even, so many studies from India have shown that you use this even in type 2 diabetes patients, as an education tool, patient education tool. Patient sees what is happening. Even once in 6 months leads to better glucose outcomes. So when you talk about, the cost of, this is how I explain patients, you talk about the complications of diabetes going ahead, you talk about the cost of complications of diabetes, that is much higher than spending a one time, on this, which is actually going to help you. But right now I see that many companies, even Dr. Saptarshi can say, many companies are actually giving it, for free for children with type 1 diabetes especially.
Uh, what is the youngest child you put this monitor and which successfully you can treat, madam? Your experience.
So the youngest child that I have been able to put this on is about 7 years. I have not used it in a child less than 7 years. So at my center, we have a free program running. We have about 100 children on the program enrolled, which is primarily, which has been running from a long time by Department of Pediatrics, and patients who are not actually doing well on this are referred to us. So we don't, actually see the regular ones, and the youngest patient that I've seen is about, 7 years on this.
Because what I feel nowadays the cases those are reporting is very high, and because of this mall, see the children those are becoming obese children. That's what we from IAP we are concentrating on this. So because of the nutrition status is the one is going to decide on the child health later, like, and as well as you mentioned the lifestyle also. So excellent talk, madam. Really nice. I think. It's a very worth to be there. And the program what our Delhi IAPS are doing, there's a very good series, and it is I think it is worth to be continued. I am thinking of we'll doing even Karnataka IAP also such certified programs. It's really excellent. Thank you.
Thank you, sir. Thank you.
So I think we can take the questions which are there in the chat box. Dr. Naveen has asked, maybe not directly related to today's presentation, but still I will put forward the question. So if a person has anemia as a comorbidity, about how much value of hemoglobin is suitable for interpreting HbA1c?
So we don't have a cutoff. Various studies have studied this and found the values are actually falsely high or falsely low based on the hematocrit and polycythemia that we spoke about. So we don't have a cutoff. So at any lower levels of anemia, there could be the fallacy of the results. And only if your hemoglobin levels are in the normal range, then you can be interpreting the HbA1c values.
Yeah, especially in case of iron deficiency anemia, what happens, the RBCs tend to have a longer lifespan. So the HbA1c, in fact, actually tends to be falsely higher because of the longer lifespan. It's a percentage, so you might be slightly getting erroneous results. So it depends again on the type of anemia and the lifespan of the RBCs, which will determine. We don't have an exact cutoff. Anything above 10, 11 should give you an approximately acceptable result. Anything below that, so it needs to be interpreted in the context of the type of anemia and the RBC lifespan. So we have another question. So if we have a child with type 1 diabetes, so once he or she recovers from diabetic ketoacidosis, so what will be the approximately schedule for monitoring blood glucose, and what should be the long-term plan like? Dr. Lakshmi.
So 7-time SMBG is what is recommended by most authorities whenever if the patient a pre-meal SMBG, and you can do a post-meal SMBG, you can do a 3 a.m. SMBG, and also if the patient has symptoms of hypoglycemia, experiences symptoms of hypoglycemia, then you should be doing this. But after a first diagnosis of type 1 diabetes, I would like to again tell that you should be checking with the lab value and should not go on the glucometer value as such.
Thank you, Dr. Lakshmi. I am not very sure whether we should be answering the next question or not, because he has asked Dr. Chiranjeev that brands of both glucometer and also GSD strips. So again,
So can we answer this?
I think we all know the standard brand, so it's slightly difficult to recommend just one particular brand in this situation. So you can, obviously there are advantages and disadvantages, and there are, even within a brand there are lots of variations and options available. So you can and there are reading materials related to all of them which are available. So if there are Dr. Adarsh, Dr. Vipul, Dr. Rajiv, if you have any questions, or we can thank Dr. Lakshmi for a wonderful lecture. But before that, any questions from anyone? Any other questions?
I think the way Madam Dr. Lakshmi she spoke, it is a really fluent talk actually. I think she made us understand what is the importance of continuous monitoring and how early we can prevent all the complications. I think it is a really excellent. It is my compliment, Madam. It is really excellent talk you are given.
Thank you, sir. Thank you so much.
Dr. Vipul.
Thank you, Dr. Adarsh, for joining. Dr. Adarsh is National EB of Central IIP, and I think it's his second consecutive year with of being a executive member of Central IIP, and we had him last year in Delhi, and it was very heartening to interact with him that time. And thank you, sir, for joining from your busy schedule, and thank you, Dr. Saptashi, for moderating the session today. And extremely thankful to Dr. Lakshmi for taking out time. And I disturbed her a lot in last 1 week. And thank you
No, not at all. Not at all. Thank you. Thank you so much for this opportunity.
for an excellent talk. And it was, I think this talk is on YouTube. We can listen it again and again. We'll share the link once it is up.
Yeah, I think many of us actually need to go through it again because she, it's a complex topic. So
Yeah.
and she covered it very in a lucid way and made it simple. But I think we'll need to go through it again once or twice to have a full understanding of it. Again, thanks all of you. We have our next meeting
Next Sunday,
on
11 a.m.
next Sunday.
Yeah.
So hope to see you all of you. Thank you, Dr. Vipul. Thank you, Dr. Adarsh. And
Thank you.
lastly, a huge thanks to Dr. Lakshmi for an excellent talk.
Bye, sir.
Thank you.